So, hello everyone. We are back again with Mr. Jaanus Pikani with us. Mr. Jaanus Pikani is a well known delegate from the Estonian Embassy and he would be talking about digital health today. So, how are you, sir?
Thank you. I'm fine. Nice to be nice to be with you.
So, he's nice to be here. So, we'll talk about digital health all together. First of all, the primary question that I would like to ask him is like, what do you think digital health is, Mr. Jaanus?
Digital health has actually enabled us to do a lot of developments in healthcare and to actually address the new problems, new challenges. What we have, increasing number of patients in the Western world. We have actually aging population, which means much more um, problems, much more multiple diseases, much more diseases because if people live longer, they get more diseases, more problems. And from other hand, this also needs and puts some more pressure to the health professionals to change for the change and to the innovation means that you need to do something different.
Right. So since you talked about change, so India is not the country where people are very susceptible to change, right? So how would you say what are the challenges for digital health adoption in India or any other country wherein people want to get digital health but they do not want to adopt that change?
So, of course, it's easy to theoretically talk about the
Right.
digital health, but in each country, the medicine and professionals are trained to be conservative,
Right.
which is actually fair because the main principle is do not harm.
Right.
And the other thing is, in most countries, the professionals, nurses, doctors are actually very much overburdened and to actually take a new ways to treat, new practices, new pathways, you need to actually devote more time for this.
Right.
And this is a problem that how to actually get and invest time to something new when you have backlog of work to do from your day-to-day activities.
And how do you think we can overcome these challenges?
Well, this is to make these digital tools
Right.
more sort of intuitive,
Mm-hmm.
that you don't that are more simple to use,
Right.
and that the actual adoption hurdle will be lowered. This
Right.
is the first thing.
Right.
But the other thing is, of course, you need to actually start from early on when you develop this.
Right.
To do this like co-creation with the people who are intending to use this.
Right.
And the third is that if you do this, you have to invest not only the doctor's time, but the time from people and effort who should actually guide those professionals or train those professionals.
Right.
That this is done in most efficient way.
Right. So, in order to summarize what Mr. Yano said to us, he just said that we basically have to do everything from the root level, grassroots level. We cannot just take digital health to the uproot level. We have to start everything from the basics, right? That is what you said right now.
And also, we need to say that we don't definitely every new digital solution doesn't need to contain new medical knowledge.
Right.
Because there's a plenty of actually existing medical knowledge that can actually put in digital form,
Right.
to put to the algorithm,
Right.
and just create tools that enables us to do the work much more cost efficiently and efficiently and a better quality.
Right.
So let's take in this way that further formerly, if we had a paper-based
Right.
records,
Right.
it took already some time for the doctor if the patient came
To look
see,
for everything,
to
yeah.
look and to see what was actually the patient case. Today, these digital tools can
Yeah.
actually enable to actually process and analyze the pre-existing data already in a way and present it that in a glimpse, in a 1 second, patient, the doctor or nurse can understand what has changed from the previous visit.
Right.
And what is a patient study? What is a problem? If
Right.
you have either your blood sugar is actually just in under the curve, or you need to actually look and see, or blood or your blood sugars.
So they can possibly look at everything a
Everything.
patient has went through in the past decade or past year.
Yeah, you can have a dashboard.
Right.
What formally you need to find the pieces of information in different parts of the patient records, or even just to look for patient recorded paper-based information or talk to patients. So makes it definitely more efficient, but every time you need to get to use to how to use it. Like we started to use the calculation software spreadsheet like Excel.
Right.
I remember 25 years ago they were so complicated. Today it's like more intuitive.
Right. And those could also be analyzed for the future purpose. Because right now we are talking about AI. We are talking about AI in healthcare, in diagnostics, in clinicals. But we haven't talked about AI reading patient records and then after giving sufficient results so that future diseases or future epidemiology could be reduced.
So here I would say that I need to just to hold your enthusiasm a bit, because we have gone through this for example, in Estonia.
Okay.
When we thought that we can actually overcome the need to standardize and harmonize the text that computers can understand, but you can use a free text.
Right.
And that we have very, very soon, or it should be already now, we have started 10 years ago, just to have this machine reading tools that could actually understand text.
Right.
But it seems that the actually text is much more complicated. Even if you look at the Google Translate,
right,
they can actually translate something, but the AI doesn't understand what it translates.
Right.
And you can have quite a different, and especially if you have medical text,
right,
which is difficult. We had an example that we did the research on the actually obstetrics ward in a university hospital, just letting all patient charge through this program,
right,
and to see what was the result. The result was that the average mother was 59 centimeters long.
Okay. The average model is 59 centimeters long.
It's actually, didn't understand what this is, because it still takes a lot of time. That's why we now talk that we need to standardize, like SNOMED or whatever, that the most of the information need to be standardized data form, not the free text.
Right.
Maybe we reach to this level that we can actually use a free text, maybe in next decade or two, but today it's far away.
We have to have data in standardized form so that we can read it accordingly, right?
Because the apps, the diagnosis support apps, they still need some normalized and structured data,
right,
which is not easy to get.
Right, but in the future, AI will be reading it all.
It will be, but in the medical field,
right,
you cannot speak about the probabilities.
Right.
If you say, it's 90% exact.
Right.
But what's about 10%?
Right.
And this is, and then who takes responsibility? It's same like self-driving cars.
Right. We
have nearly all the technology, but those last 5% is actually reason why we don't have the self-driving.
That is the gap we have to bridge.
Yes, because even if human makes errors,
right,
then we understand this.
Right.
If there is a traffic accident,
right.
But if actually machine makes it, then we don't accept it.
Right, of course. So here comes my next question from the same line. Adoption of technology could come with its own drawbacks.
What do you mean?
Like technology could be very useful,
yes,
but it could shut down at times. Like I have seen hospitals which are completely running on technology, and suddenly the server gets lost.
Well, in this case,
yeah.
You have to have always backup system.
Right.
So this is unacceptable, and of course it happens anyway. But
right.
If you have today, we see this cyber security attacks like ransomware demands,
right.
locking the systems.
Right.
Of course, this is a major problem, and of course there are always a problem, the data leakage, data breach. So these are things what we need to address, and that's why the federated systems,
right,
where you don't have one huge database,
right.
is preferable. In In Estonia, we have all data in different locations,
Stored at different locations, yeah.
different servers.
Right.
And if somebody starts some procedure like prescription,
Right.
electronic prescription, then the actual system goes and picks up the data from different databases. One is from the doctor's database, the other is from the insurance database, the other is the third queries to the medicine database registry, and everything brought together, the citizens database, just looking together, and then it forms the prescription. It's not just it's everything is in one day.
Right. So you're talking here about a decentralized network, which you unite at times, so that it cannot be hacked.
Yes.
Easily.
It can, but it's still much more complicated because each those database, there is entrance and there is security systems, and the connection with them is actually safe. They are actually what do you say? Encrypted.
Encrypted, yeah. So, Mr. Jaanus, one more question from you. If you want to give any advice to clinicians, doctors, innovators out there for adoption of AI in health, what advice would you give to them? Like, should it be slow and gradual, and how they should get about?
Of course, if we speak about just the digital health, which doesn't give the self-learning AI, then it's easier.
Right.
Then it's still you have fixed algorithms. You can always check the algorithms, but as you know, what has happened already in European Union, it will become more bureaucratic.
Right.
Because the process to actually get with a digital diagnostic tool to the market in the European Union means at least 3 years different. You need to have a CE mark.
Right.
And the process to get the CE mark means, of course, which class and how big risk medical device is, because also software is considered in European Union as a medical device.
Right.
For all software which actually gives some advice on diagnostics or prevention or treatment, considered class 2A.
Right.
The highest class is class 3, which means implants.
Right.
And some life like ECG during open heart surgery, for example. So this is means that we have to be patient,
right,
and we have to see that especially the AI component, we don't know how to actually validate those.
Right.
If we have clear understanding how we validate and clear methodology, then it's, I think, will be exploding of AI. But today, this is still open question how to validate the AI self-learning AI systems. And if you have just an algorithm, which you know what is your algorithm,
right,
and you can present this,
right,
then you can check it. And if there's a bugs, you can check it as for example, as laboratory testing. You have test samples you send to the laboratory, and you have referral laboratory which actually check and says, yeah, you've got the same result as our test sample should have.
Right.
But if you have AI, nobody knows what's the answer.
Right. But still, standardization is important, and I'll leave the conversation open on the topic that whether AI be used in the future or not. So here was my time. Thank you, Dr. Jaanus, for being with us, and it was lovely speaking to you. And we'll come back again. Thank you. Stay healthy.
Thank you. My pleasure.
Thank you, sir.
Thank you.